Hello, everyone. Our presentation is about CSF imaging. At the beginning, we'll go through general information about CSF. CSF, as we all know, is a clear, colorless, slightly alkaline liquid with low specific gravity and very few lymphocytes. The volume varies with age, and as per kilogram, it's usually 4 milliliters per kilogram in infants, drops to 3 milliliters during childhood, and 2 milliliters during adulthood. With an average of an adult, basically depending on the body build, but it ranges between 100 to 200 milliliters in volume. The production rate ranges between 20 to 25 milliliters per hour, and the pressure also ranges between 70 to 200 milliliters of water. It constitutes similar components like protein plasma, the proteins, the glucose, and the electrolytes, particularly chloride. CSF is produced through the choroid plexus, and the choroid plexus histologically is formed of a network of leaky capillaries with minimal positive pressure within. These leaky capillaries, because of the lack of the basement membrane and tight junctions, leak some of the plasma contents, including the proteins, the electrolytes, and the glucose, into the surrounding interstitium, which gets pumped through the sodium-potassium pump, ATP pump, through an overlying layer of columnar ciliated cells. So the leaky plasma-like content leaks from the inside the capillaries into the interstitium, then through these columnar cells and the open pathways and the gates, because of the, again, lack of the tight junctions, leaking into the subarachnoid space. This is how the CSF is being produced. These are the columnar cells, and these are the cilia, and this is the capillary level. These are basically the microscopic appearance for this histological structure. CSF then circulates through the ventricular system into the subarachnoid space and then gets absorbed into the urosinuses. The major areas of production from the choroid plexuses in the body and the trigones of the lateral ventricles, where it leaks through or passes through the foramina of Monroe into the third ventricle. It is also being produced through the choroid plexus in the roof of the third ventricle and the roof of the fourth ventricle. So the CSF circulates from the lateral ventricle through the foramina of Monroe to the third ventricle, through the aqueduct of Selbius into the fourth ventricle, then through the foramina of Magindi and Luschka into the subarachnoid space. Minimum amount also goes through the central spinal canal. From the subarachnoid space, it gets absorbed via the arachnoid villi. The arachnoid villi are basically projections of dura mater, projections that pierces the dura mater with positive pressure of CSF inside into the negative pressure of the dura sinuses. So the CSF contents leak or seeps out from these arachnoid villi into the dura sinuses, where it gets absorbed into the general blood circulation. So what are the main functions? It's basically protection of the brain against head injuries and impacts, as it works as a buffering zone. It also helps in floating of the brain, because the brain is rather heavy with a total weight of almost 1.5 kilograms. But because of this surrounding fluid that keeps it floating, it decreases its appreciable weight to only 50 grams, which makes it easy for head lifting. Also, it helps in excreting the waste products, as we mentioned, where it gets circulated into the urosinuses, and also balances the endocrine and neurosubstances and neurotransmitters balance between the brain parenchyma and the general circulation as well as the CSF itself. The flow pattern was studied and heavily actually with the introduction of MR imaging of CSF flow with certain sequences targeting the flow pattern. As we said, the CSF flows from the lateral ventricle into the third ventricle, then through the aqueductive Salvius to the fourth ventricle, and then seeps out through the foramina of the fourth ventricle into the subarachnoid spaces. Now, this movement is not a constant forward movement because it actually varies with the pulsation within the brain parenchyma and within the circle of Willis that corresponds to that cardiac cycle. So with systole, there is a forward movement of CSF from the ventricular system into the subarachnoid space. With diastole, there is a regressive movement or a return of some of the CSF back in a backward fashion. So it's a to and fro movement. And you can see this clearly on this CSF flow study, where actually the signal intensity of the fluid of the CSF in the subarachnoid space varies between systole and diastole, indicating the forward and backward sort of a turbulent movement, to and fro movement based on the cardiac cycle phase. These are the main indications for CSF imaging, primarily the hydrocephalus with the different types of hydrocephalus, and the benign increased intracranial pressure, so-called, previously called pseudotumor cerebri, the intracranial hypotension, and meningitis. There are other indications, but for the sake of time and the sake of concentrating in this presentation, we will limit to these 4 items. So let's start with hydrocephalus. There is the two main types of hydrocephalus, the communicating hydrocephalus and the non-communicating hydrocephalus. The communicating hydrocephalus could be of congenital basis, could be secondary to previous subarachnoid hemorrhage or meningitis, or could be due to a communicating very uncommon type, which is the normal pressure hydrocephalus. That represents less than 0.5% of general dementia cases and hydrocephalus cases. Non-communicating hydrocephalus is due to obstruction, as the name indicates, which could be congenital, like aqueductal stenosis, or the presence of a mass, like this colloid cyst obstructing the foramen of Monroe with secondary CSF obstruction, or a mass lesion that's obstructing in the posterior fossa and effacing the aqueductive Salvius and the fourth ventricle, secondary to mass lesion. In cases of obstructive hydrocephalus due to congenital reasons, such as aqueductal stenosis or a presence of a web, this is a web at the base of the aqueductive Salvius, while this is aqueductal stenosis, then there are 2 ways of resolving this. We have to divert or shunt the fluid that is accumulating in the ventricular system directly into the subarachnoid space. And you can do this through the traditional way of placing a shunt, which might not be ideal considering the complexity of the surgery, the complications that are associated with the surgery, as well as in case of children, because you need to revise the shunt as the child grows and the need for a longer tubing rises. Then the other solution is to do the third ventriculostomy, where with a ventriculoscope, you go through a transcortical approach through the corpus callosum, going to the lateral ventricle, then through the foramen of Monroe into the third ventricle. And in the third ventricle, you make a hole, a fenestration, or a puncture through the floor of the third ventricle, making a direct communication between the third ventricle and the subarachnoid space in the prepontine and the interpeduncular cistern, allowing the fluid to decompress directly into the subarachnoid space. This is a case of aqueductal stenosis, where you can actually recognize that there's lack of CSF movement at the anatomic location of the aqueductal Salvius, as it's compared to the normal pulsation of of CSF in the subarachnoid space, indicated here by the tripontine cistern and the interpeduncular cistern. So as I said, with the ventriculoscopy, you place a scope, transcortical approach, then into the third lateral ventricle, negotiate through the foramen of Monroe into the third ventricle. And as you look downward on the floor of the third ventricle, this is what you see, and you puncture a hole at the location anterior to the mammillary bodies, and you make a direct communication through the third ventricular floor between the third ventricle and the interpeduncular cistern and supra and prepontine cistern, decompressing the CSF. This is before ventriculostomy, and you can see CSF pulsation in the prepontine cistern with lack of pulsation into the ventricular system. After the ventriculostomy, you can see that communication being proven by visualization of flow through the defect that was created at the level of the floor of the third ventricle. That is third ventriculostomy. Again, you can see you can puncture a hole in here, and after the puncture of the hole during systole and diastole, you can see the forward and backward sort of to and fro movement, pulsating movement of the CSF through the patent ventriculostomy hole. In communicating hydrocephalus, it's quite a different situation, but we judge it by the degree of ventricular dilatation, the stretching of the corpus callosum, the effacement of the cortical sulci against the inner table, as well as the degree of the dephasing artifact, the loss of the normal white signal of the CSF that we see on T2 and relatively on proton density. With the dephasing artifact, you get loss of the CSF signal at areas of narrowing as it passes through the aqueduct of Sylvius into the fourth ventricle and then through the foramen of the fourth ventricle. The degree of the signal loss corresponds to the degree of dynamic and activity of CSF pulsation in the ventricular system. This is actually magnified selected images from the previous slide, showing you the dephasing artifact, the loss of signal of CSF through areas of narrowings, indicating hyperdynamic CSF flow through the foramina of Monroe, the third ventricle, down to the fourth ventricle. This is best illustrated in cases of normal pressure hydrocephalus. Normal pressure hydrocephalus is an uncommon type of communicating hydrocephalus, and it represents actually less than 0.5% of dementias. It was first reported by Adam and Hakim in 1965 with a certain criteria, clinical criteria of cognitive decline, gait disturbance, urinary incontinence, with a normal lumbar puncture opening pressure. The CSF analysis should be also normal. Bradley identified that if you measure the CSF flow within the ventricular system through the aqueduct of Sylvius, you will realize that it is a hyperdynamic CSF circulation. And that is one way of identifying normal pressure hydrocephalus, since these clinical findings are rather nonspecific and overlap with so many other types of dementia. Now, the treatment for NPH is shunting. However, shunting may not be successful in all the cases, and actually success rate drops to almost 50% if you have non-classical presentation. Also, BP shunt is not without complications, and complications could be up to 30% of cases. This is why what Bradley did in 1991 of studying CSF flow through the aqueduct of Sylvius, trying to identify a certain measurement beyond which we can call the CSF flow as hyperdynamic, and subsequently identify those patients who will benefit from shunting, is of crucial importance in minimizing the risk of failure of CSF flow studies. Now, it is true that within the clinic, if you decompress the ventricular system by a lumbar puncture, there will be a transient improvement in the gait disturbance, but this is a temporary measure and cannot be used as a measure of treatment, as it needs to be repeated every few months. So by MRI, what we look for is, we look for certain findings. We look for ventriculomegaly, enlargement of the ventricles, with dephasing artifact, loss of the normal signal intensity of CSF at areas of intraventricular narrowings, the foramen of Monroe, the third ventricle, the aqueduct of Sylvius, and the fourth ventricle, as it is indicated in here. We also look for the stretching or the upward bowing of the corpus callosum. We also look for the effacement of the cortical sulci against the inner table of the skull, the calvarium. We look for the periventricular high signal intensity, which indicates the shear injury of the periventricular fibers. Now, if you understand how it works, basically with the pulsation of the cardiac cycle that is being transmitted into the circle of Willis and the arteries that are located on the surface of the brain, these pulsations are being transmitted through the brain parenchyma down to the ventricular system. So the ventricles are being pushed and compressed quite aggressively. This kind of pressure movement and injuring the periventricular white matter, resulting in these areas of gliosis, secondary to shear injury, and they also result in the exaggeration of the pulsation artifact of CSF within the ventricular system, hence the dephasing artifact we see at areas of narrowings. If you measure the CSF flow through the aqueduct of Sylvius by applying CSF flow study, which we will come to you to discuss in a minute, and we reach a measurement of 42 microliters or above, then this indicates that there is enough increased CSF hyperdynamic circulation that justifies CSF diversion treatment, i.e. shunting. So if we go to these factors again, and take them one by one, CSF signal intensity void actually has the best correspondence and correlation with NPH, because it is present in 80% of the cases with high significant correlation. And there is actually a grading system for how much of signal loss can be appreciated. Obviously, grade 0, there is no signal loss, and grade 4, there's signal loss that extends from the from the lateral ventricles down to the fourth ventricles. And in between grade 1 and 2 and 3. So you can grade the degree of signal void loss, signal loss or signal void that is created by the hyperdynamic flow nature of CSF. Ventriculomegaly is also present in about 70% of cases, and it is the second most reliable indicator for cases of NPH, particularly in cases where there is no significant parenchymal loss, because parenchymal loss may indicate other types of brain parenchyma with generalized brain parenchymal volume reduction. So if you have ventriculomegaly that is out of proportion to the degree of brain parenchymal loss, then that's a second most important indicator for increased likelihood of NPH diagnosis. White matter high signal intensity is also present in about 60% of cases. As we have discussed before, it is actually due to the compression of these fibers in a pulsation manner against the dilated ventricular system. The bowing of the corpus callosum is identified in 50% of the cases, and this is basically because it is also present in the majority of cases of hydrocephalus. The ventricular, the sulcal effacement against the inner table is present in about 60% of the cases as well. So when you have a case of clinically suspected normal pressure hydrocephalus, and you do the MRI study and you identify that there is bowing of the corpus callosum, there's ventriculomegaly, there's effacement of the cortical sulci, and there's significant dephasing artifact of CSF across areas of narrowings, then what you need to do is the CSF flow study, where you take one cross-section image across the aqueductive sylvius, perpendicular to the long axis of aqueductive sylvius, to visualize the brainstem and the aqueductive sylvius, and you'll apply the CSF flow study in a full cycle, systole and diastole, to identify the CSF flow in forward and backward fashion, to and fro, during a full cardiac cycle. And you can do that in axial as well as in sagittal, identifying the to and fro movement of CSF between the subarachnoid space into the fourth ventricle, the aqueductive sylvius, and the third ventricle. By doing so, you can also measure the diameter of the aqueductive sylvius. The sequence also gives you a graphic representation of the systolic and the diastolic movement of CSF across the aqueductive sylvius by deducting the systole from diastole and then multiplying it by the diameter of the aqueductive sylvius. You get the CSF flow study, the CSF stroke volume. If the stroke volume is more than 42 microliters, then this indicates hyperdynamic circulation corresponding to a higher risk of being an NPH patient. Secondly, those patients will benefit from shunting procedures. Moving forward to benign increased intracranial pressure. It's a clinical condition. Again, it is a diagnosis of exclusion. However, there are certain criteria. Usually, it's increased intracranial pressure with unknown etiology, commoner among younger women. Usually, it's of unknown reason, related possibly to weight loss or hormonal disturbance. Yet, it also could be secondary to neuroscience thrombosis or subarachnoid hemorrhage, or certain medication being ingested. The most common presentation is with headaches, possibly with some visual blurring and tinnitus. However, retroorbital pain, diplopia, visual loss, and painful eye movement have been also reported. Since these findings are rather non-specific and are also overlapping with so many other neurological diagnoses, the diagnosis remains rather of exclusion, depending on the clinical presentation and documentation of fundoscopy, identifying papilledema, and then opening pressure of lumbar puncture of more than 200 millimeter. That usually gives you the diagnosis. The CSF analysis is usually normal. However, there are other ways to diagnose this with less invasive procedure than doing an LP, which are basically applying MR sequences, targeting the brain and the orbits. The CT scan and the MRI of the brain are usually normal, mainly visualizing some small or slightly compressed replaced ventricles or an empty cella. However, if you look at the MRI of the orbit, you see most of the findings that are of diagnostic value, as we would indicate in the next slide. This is a normal study of the orbit in the first row. The second row is a case of benign increased intracranial pressure. As we said before, the brain MRI could be normal by itself. However, if you look at the orbit, look at the optic sheath distension, comparing the normal with the abnormal, the distended sheath in relation to the optic nerve. We published before a study indicating that if the ratio between the sheath and the nerve is more than 2.5, 2.5 times, then that's usually corresponding to opening pressure more than 200. Now, when you take these cross coronal images, don't take the first cut that is retrodiscal, because usually the CSF accumulates here naturally. So you go to a midsection and a posterior third section, a midsection and a posterior third section of the orbital segment of the optic nerve. And you can see the optic sheath distension. Also, you identify the optic sheath distension on the axial image all the way through with kinking of the nerve. This is in horizontal and in coronal sequences, showing the normal and the abnormal, how it is kinked and distended and kinked. Similarly, you can see the flattening of the optic disc Sometimes you see it even raised, indicative and corresponding to the papilledema visualized by fundoscopy. So let's move on to spontaneous intracranial hypotension. Let's start by historic background. Monroe, who is a Scotch anatomist who actually described the foramen of Monroe, developed a thesis with Kellie, who is another Scottish anatomist, where they came to identify that since the skull is rigid and the brain parenchyma is incompressible, then the volume of the blood should be constant, and since it is circulating, then the amount of blood flowing in should be equal to the amount of blood flowing in through the circle of Willis and flowing out through the aqueduct, through the dural sinuses. The amount of flow should be constant and equal to keep the nourishment of the brain and maintain the normal volume within the skull, since, as we mentioned, the skull is not expandable and the brain parenchyma is not compressible. However, they ignored completely CSF presence, as they thought that there's no fluid within the ventricles, but rather there's humid gas. It was Magendie, after whom the foramen of Magendie was named, who actually identified the presence of CSF by doing a cisternal tab, so documenting the presence of fluid within the ventricular system. Harvey Cushing, the famous neurosurgeon in the early 1900s, formulated the formula of Monroe-Kellie hypothesis, saying since brain and CSF and stating that brain plus CSF plus the intracranial blood should be a constant volume. Since the brain is constant, then the changing factors should be the CSF as the blood by the amount of flowing in and flowing out, and CSF by the dynamic circulation and exchanging the CSF between the intraventricular and the subarachnoid spaces through the foramina, through the ventricular foramina. The initial diagnosis of spontaneous intracranial hypotension was proposed by Schultenbrand in 1938, and he thought that this is due to complete absence of CSF, and it is of spontaneous nature, so he called it spontaneous equiliria. However, later on, he rephrased it into rather decreased amount of CSF, hypolichuria rather than alichuria. So, in case of CSF volume reduction, a compensatory intracranial congestion by hyperemia will happen to compensate for the volume reduction. We said that the brain parenchymal volume is static, it is fixed, it is not compressible, it is not changing. Now we've got less amount of CSF, so this has to be compensated by the other changing factor, as mentioned by Harvey. Brain is constant, now we have less CSF, so blood flow has to increase. This is why in cases of spontaneous intracranial hypotension, you get venous engorgement, you get meningeal enhancement and hyperedema, hyperemia, and you get congestion of the pituitary gland. And even if that all fails, then subdural collections start to develop, all compensating for the vacancy that was created by the decreased volume of CSF. So if you do the MR imaging, what you're going to recognize is dural sinus congestion. As you can see, the dural sinuses are congested and rounded and prominent. You may see congestion of the pituitary fossa, pituitary gland. You see enhancement of the dura. You see enhancement of pachymeningeal dura all the way through. And you may also see some dural collections. How about the spine? You'll find the same findings within the spine. However, they're more subtle and more difficult to identify. This is the anterior reflection and the posterior reflection of the dura, and this is epidural collection. Similarly, this is a thin layer of the dura, and this is epidural collection. Then you may also see it in the form of diverticuli, particularly among patients who have connective tissue disorders such as Marfan syndrome. So spontaneous intracranial hypertension was thought to be a rare condition. However, with the common use of MRI, it is becoming more and more recognized. It is commoner in females than men. The International Headache Society published in 1998 a certain classification of low CSF pressure, whether it is idiopathic or iatrogenic. I will leave this slide for you to read. It is beyond the scope of the imaging. However, we know that it is commoner among patients with connective tissue disorders, such as Marfan syndrome, such as patients with some fibrillin 1 gene mutations. And it could be due to iatrogenic causes, particularly any procedure that violates the blood-brain barrier, whether that is craniotomy, spinal surgery, a shunt, or even a lumbar puncture procedure. So, usually those patients present with sudden onset headache that is usually postural in nature, related to standing and relieved by lying flat. And it is sort of holocranial all over the skull, not specifically to any particular area, although it might be more frontal or occipital. However, the majority of cases are rather holocranial in nature. They may be associated with double vision, secondary to sixth nerve palsy, photophobia, nausea, vomiting, hearing loss, malaise, etc. How do we diagnose this? Obviously, the most common and less invasive is actually doing MRI, and it is important to do that before doing an LP. And MRI will show you the findings we just discussed of the engorgement of the intracranial circulation evidenced by the dural sinus prominence and congestion, the congestion and the enlargement of the pituitary gland, the enhancement of the brain parenchyma, all this as a compensatory mechanism for the relative reduction of the CSF volume. Also, you may see, as we mentioned before, some dural collections, subdural or epidural collections. If you do an LP, this should be very carefully done because it's a critical condition and there's a possibility of brain parenchymal compartmental herniation. Let me explain this further. If we go back to the images here, with the decreased intracranial pressure, you see there's effacement of the cisterns, the prepontine cistern, the interpeduncular cistern. There's sagging of the tonsils, of the cerebellar tonsils occupying the cisterna magna. So putting an LP and draining some fluid might put the patient at risk of herniation. So that should be done carefully. Not infrequently, because of the low pressure, even with proper placement of the lumbar puncture, you may not get any fluid, CSF fluid drainage, particularly if the intracranial pressure less than 60 millimeters. However, if you do analysis of the CSF, it should be a normal CSF analysis. We're not going to go through the management. There is some medical management and there's some surgical management. You can read about this and expand your knowledge on that separately. One of the long-term consequences of intracranial hypotension with the chronic congestion of the dura and chronic distension of the dural sinuses, you get dural fibrosis, which gives you the classic appearance of pachymeningeal enhancement. Finally, we go to meningitis. This is the last item in today's presentation. In meningitis, the clinical diagnosis is clinical. We do the MRI to identify complications such as meningoencephalitis, abscess formation, empyema formation, presence of hydrocephalus, and brain edema. Obviously, MRI is much more specific than CT in diagnosis of cases of meningitis. Obviously, we need to give contrast to improve our sensitivity for identifying all the possible complications. If you do a CT, should be not more than 5 millimeter slice thickness, should be actually 3 millimeter, maybe 3 millimeter in posterior fossa, 5 millimeter in the supratentorial structures, and should be with contrast. The MRI should also have contrast. You should get pre and post gadolinium T1 and FLAIR images. You should get axial and coronal T2 as well as diffusion and ADC map. One of the easy signs to identify is the hyperintense sulci or hyperintense CSF images on non-enhanced FLAIR. These are non-enhanced FLAIR images showing the CSF within the sulci, within the subarachnoid space, being hyperintense. As we all know, CSF on FLAIR images is dark, but in the sulci, in cases of meningitis, will show high signal intensity. This is due to high proteinaceous content. Now, this same appearance might be identified in cases of subarachnoid hemorrhage or cases in patients who have who are hyperinventilated in an ICU setting. But in cases of meningitis, this is one of the early signs you identify, the hyperintense or the bright sulci on FLAIR images. Again, bright sulci on FLAIR images, and this is the T2. You may not identify it on the T2, obviously, because CSF is bright anyways. However, on FLAIR, it is very clear. When you give contrast, you see the leptomeningeal enhancement. We said before, with the intracranial intracranial hypotension, you get pachymeningeal. Pachymeningeal is enhancement of the dura mater. It bridges over the sulci. It does not go into the depth of the sulci. With meningitis and with metastases, also you get leptomeningeal enhancement of the meninges, the PM matter that goes into the depth of the sulci. Obviously, you can see that there's ventriculomegaly. Maybe you cannot identify it in the lateral ventricle or the third ventricle, but it is easily identified within the temporal horns because the temporal horns should not open up at all in normal intracranial pressure. Again, a case of meningitis, you can see the extensive leptomeningeal enhancement and the ventriculomegaly and the opening of the temporal horns, the ventricular enlargement. This is classic leptomeningeal enhancement with also areas of parenchymal enhancement, punctate areas of abscess formation in the region of the basal ganglia. In cases of TB, tuberculosis, you get even an extensive basal meningitis, sugar coating over the basal meningitic coverings over the brainstem and the media aspect of the temporal horns. You may also see selective areas of meningeal and parenchymal punctate areas of enhancement indicative that tuberculomatous and the surrounding satellite tuberculomatous as well. Hyperintense on the proton density with the strong meningeal and parenchymal enhancement. You can see here selective enhancement within the sylvian fissure itself, and the strong and the fairly prominent ventriculomegaly. Again, just to ensure that that you identify the difference between what we mean by pachymeningitis. This is enhancement of the dura mater. It bridges over the sulci. It does not go into the depth of the sulci. This is pachymeningitis versus leptomeningitis, which is enhancement of the PM mater in cases of infection, meningitis, as well as metastases. So that's leptomeningitis. By this, I think we end our study. Sorry, one last slide showing the sort of empyema collection in cases of complications of meningitis. By this, we end our presentation for CSF imaging. I hope it was useful. And I strongly advise you to read more about this subject. There are so many other areas that are not covered within this presentation for the sake of time and the length of the presentation. And I advise you to read about this, particularly the literature that was published in the early 2000 by William Bradley, and some of the literature has been quoted within the this presentation. Thank you very much.